take the next case, which is a synergy IOL. So just to showcase this new lens, which is a combination of the multifocal techniques, multifocal, and the symphony, which is the elongated vision which it gives. So it again uses a diffractive pattern here, and what we have seen in our patients, the glare and halos are comparatively less as compared to the other multifocal lenses, and along with that it gives a elongated range of vision also, which makes it more good for near as well as for intermediate vision. And this patient is around file dikha do. So when we are choosing these any multifocal lenses, multifocal or whatever we say, quadrifocal, trifocal lenses, so very important is the patient counseling. We थोड़ी आवाज़ कम रखो यार प्लीज़, ये थोड़ा नीचे कर दो. So the chances we have to ask, the history is very important. 1, 2, very important is what is the job profile of the patient, what he wants to do, and we try to avoid such lenses where the patient is very apprehensive from the beginning. It is said that a long chair time before the surgery, you can do good, and if you spend lot more chair time after the surgery, it will make patient apprehensive, and if you do it before, it will make patient relaxed. So this we have to tell. We have to ask specifically because most of the time the complaints are about the halos and glares. So we definitely need to ask what sort of driving and other activities the patient is into, because that becomes very important. This patient is a 67-year-old retired person, and his thing was he doesn't want to have any glasses because he is having some problem with his legs, and he used walker to walk also, and he said, I don't want any glasses because I won't be able to change them every time. So that was the reason we have chosen this particular lens here, and both eye are cataract around grade 2, 2 plus, and power axial length. File the other.
I guess such cases are the best ones.
Axial length is around 23.74, which is again good enough, and doesn't have any cylinder. It is just 0.45. So we have not made any LRIs. Again, a good option about the machine Catalyst is it gives you a very good limbal relaxing incisions, and now there are calculators within the machine itself. You can calculate accordingly, and you can have either a anterior penetrating or intrastromal LRIs, and in my practice normally around 1.25 to 1.4 type of astigmatisms. If patient is not willing for a toric lens, I correct up to 1.25 with these LRIs. Otherwise, I prefer to put a toric implant even if the patient has at least one diopter of astigmatism. So, but here I think there is no astigmatism, no LRI, and anything else probably?
Yeah, I guess this is a very good indication for this kind of a lens when the patient doesn't want to use glasses. So the patient satisfaction will be very high.
Yes.
So if there is a patient who wants multifocality and you have a choice between say synergy or between symphony, because from the patient point of view, it is just that he's able to see for all distance, intermediate and near. So just for everybody's knowledge or everybody's insight, how would you decide which lens to give, which patient to give Eyhance, which patient to give synergy, which patient to give symphony? How would you decide that? Will the economics decide that, or what are the parameters on which your decision is based?
Okay, firstly, I feel first first important thing is the economy, the finance patient can spend, because like as I said, I would like to implant a toric in one diopters also, but the patient at times they don't want to spend that type of money. Even in those patients, if they choose a sort of a technique or Alcon type of a lens, so I ask them preferably to choose a Indian toric lens, because that astigmatism, finishing it with the lens is more important than because uh, the which I call is the wow effect of the surgery is on day one, when patient can see a good 6669 vision on day one. As far as the multifocal lenses, definitely it is the finances available with the patient, very important too. If the same patient here, which would have sent okay to a lady who is just a housewife and just want to do household work along in the kitchen and all that, I would have chosen a multifocal lens also, which again gives the patient less to spend there, because the multifocal lenses now are a bit cheaper than these lenses now. And specifically a high profile patient, again, where patient wants to play golf also, to read, to computer, attend meetings and all that, and he doesn't have to drive, he has chauffeurs and all that, then these lenses like synergy or even panoptics and other lenses are very important. Symphony in all, probably again preferable in all those who feel that they don't want to drive much, because there it is a different technology involved, and sorry, they want to drive, so they Symphony probably I'll focus on there. But again, I have seen, not many, but I have seen or heard about patients who are not very happy with the results of these lenses, because they want much more clarity and rather I'll say a good contrast, and especially when these patients are young, very young patients, they, because again as I say, their neuroadaptation is entirely different, so initial few months they feel really bad about it, because they see the difference between a normal lens and another lens inside, and because there are definitely patterns there, rings around, so they have little bit of diffractions. So those patients, probably we need to be very patient with them. We need to tell them everything about the uh, post operatively what they will go through. So this is probably how I choose lens. Any other comments from Dr. Sinha?
No, I completely agree with you. And but this, all these lenses are very useful when the patient demands it. When the patient says that he doesn't want to wear glasses, then such a patient is very good, as this patient demanded. So such a patient is a very good patient for all these lenses, wherein you have a trifocal lens or any extended depth focus. It has been noted that the photic phenomenon are less with extended focus lens. But then of course technology is advancing, and I guess as we get to see more newer lenses, we will with lesser photic phenomena, because now the thing is that we have been able to achieve 6.6 and N6 kind of or N8 kind of with the lenses. The only thing that we have to keep on is to reduce the amount of these visual that the patient can have. And with these newer generation lenses, because of the increasing depth of focus, the increasing defocus curve, and also with other modification in the design, these phenomenon are quite they are reducing. I won't say it has gone out, but they are reducing. They have reduced quite significantly. What do you say?
Yes, I agree with you completely, Rajesh, and with also Dr. Ajay. So I think we now go to the third case, which is again doesn't look like a very soft cataract. Looks like a So this
So
is just to, yeah, very gentle hydro maneuvers are being done, and I think this is a difference that we do with a normal conventional
Uh,
phacoemulsification.
I would like to have opinion of both of you that, when we do a femto cataract, part of the dissection is done by the air inside, the bubble that is there, the gas.
yes, yes.
You have to be very gently. If we remove the gas, then it can get replaced by the fluid that we are injecting. So we don't have to be very vigorous. We very gently remove the gas, inject a little bit of fluid. That is replaced by the
Yeah.
fluid.
So most of
You
the
can get a rotation.
pneumo dissection of
Yeah, yeah,
femtodilation is already done.
absolutely. Yeah.
So yeah, totally agree with you. Because you have to be very gentle. The hydro is not the way we do it in normal manual surgeries. You have to be very gentle, just to press, inject a little bit, press, inject, so that the air comes up, and yes, it gives you a good dissection also. So this is again harder than what I thought. It's a grade 3 sort of a thing.
Perfect job.
So either you can do all 4 quadrants, you can divide first, or you can take out one. If you have the opinion that it's better to let all the quadrants be there, so that it gives a better
Yeah.
chopping. So it's
Can you just center it a bit
Can you move it towards you?
towards you? Yeah, yeah,
Now
yeah. It's perfect.
lens. एक बार दिखा देना लेंस.
So I'm sure this must be your routine, Ajay. Even half of the nucleus is out and your lens is already waiting to get ready. The surgical time is so short, and it's come almost like a textbook like picture with 4
Yeah.
quadrants, and each quadrants virtually getting emulsified in the center of the eye. And the left hand, I think it's important to see the left hand, which is moving so with such dexterity and is doing most of the job.
True.
So this is a small bit here.
So I think this is
एक
what
मिनट रुको.
we are talking about.
एक मिनट रुको, आया नहीं करना.
This fragment was just underneath the
Normal.
main.
So you could have tried it with the IA, but it takes a lot of time. Better to go in again and take that out. Again, something on the use of the viscoelastics. Very important. I tell all my surgeons here also, and just to put in viscoelastic after every step, and especially when you are dealing with these hard lenses, as I did in between. Don't shy to put in the visco in between, because especially if a dispersive sort of OVDs, they are important. Even HPMC is good enough, but if you have a combination of sodium hyaluronate and chondroitin sulfate, that is good, but again, those are expensive things, so not all the surgeons are using. But I feel HPMC can do wonders, and it has been doing wonders, and I don't know whether in my life I have used more than 10 times this Viscoat or Helon or anything. So that too, probably, if I feel yes, it is side put देना. If it will be very difficult, हाँ नहीं why या कुछ दे दे why. There is a small tag here. So this is, we're done with the
I think
eye.
very nicely shown how these small fragments or tags which are there in the initial part with the phaco probe, and in the latter part with the help of the Y or the dialer or whatever, I think one can address that. And again, very effortless implantation of the IOL. And it is really heartening to note that HPMC you use maximum number of times, because then that fear of using viscoat or fear of having viscoat or having, definitely heel on, maybe you should have it, but
Yes,
it
definitely.
is not required for all the cases.
Yeah, true. So at times these haptics, they get stuck with the optic here. So just try to tap them, and in most of the lenses, yeah, it is very easy to detangle them. But Invista is one which takes a lot much time. But
And what is your final preference of haptics? Like many people prefer putting it at 3 and 9 o'clock positions, like keeping it horizontal in order to minimize dysphotopsias.
yeah, so just a minute. So I also try to put it at 3 o'clock.
Horizontally, yeah.
So that it doesn't move, and it's easy when we can see both the haptics. सीधा करिए sir. Now in the end it is very important to see whether the lens is centered or not. So you have to adjust the head posture of the patient, adjust your microscope here. Now with these microscopes, where these high-end microscopes, we can ask the patient to, now again there is a small,
There is a question, what are your settings when you do viscoelastic removal? Do you put it at the cortex settings, or is it lower, the flow rate, aspiration rate, etc. is lower when you are aspirating the viscoelastic?
so you're asking me when
Yes, for viscoelastic aspiration.
I normally keep them the same, and it is just a maneuverability with your foot pedal. You can increase or decrease. So it is around the vacuum is 500, aspiration is 40, and और क्या है? So you can see the lenses center, the three images.
Yeah, perfectly in the center.
Yeah, absolutely centered.
एक मिनट और दे भाई.
So I think there is a viscoelastic mode in most of the machines for aspiration, but yes, even I like to just aspirate in the cortex mode only because it's faster that way. But of course, if you are beginning to learn, then it is always good to go to the visco.
Yeah, I totally agree. And all those दो ये दे दे, who don't have these, high-end microscopes and all that, it's better you can take just two instruments, take a cross here and see whether this is a center. It lies in center of this. So that is again one way to find if the lens is centered.
That's a great trick, great trick.
So this is done. What's the time? Okay. बंद करिए आँख.
So I think this is what I was talking about very nicely, Dr. Ajay. You put the pad and then the patch. Again, these are the things which we normally don't see during the live surgeries or during live demonstrations or talk about it. But they are useful, small things.
सिर उठाइए. Yes, probably this is something which I always do. Whether if you have to do 20 surgeries or 5 surgeries, because I put the patch myself. uh, I feel once you are operating and you have to close the eye, and this is what I have been doing, and probably I would like to give a message to everyone. This everyone should be doing this. Try also to evaluate your OT assistant every time you are in the OT, because it can be a new person there. How he or she is cleaning or dripping the patient, that's again very important. uh, at the end of the surgery, again I spent some time, maybe few seconds, just to see if there is any fiber or any cortex or anything inside which I need to remove there and then. So because I don't want to ask the patient to come back next morning and see, oh, there is a some fiber inside and we have to take it out. So these are certain things which a surgeon must do. It doesn't matter whether you are finishing a surgery in 5 minutes or you are finishing it in 10 minutes. Ultimately what matters is the result, the post-operative, how happy the patients are. And this is what gives a surgeon a clear benefit of his surgical strength and all. So
So there are a lot of our students also watching, Dr. Tejani and others, Ankita Agarwal. They are, I mean, really complimenting on interesting session and interesting surgery.